For our Emerging Models presentation, we collaborated with the Regional Cancer Center, known as the RCC, to promote and advocate the need of occupational therapy services. We interviewed an interdisciplinary team to discuss OT's roles and how OTs can benefit the RCC. The RCC, located here in Erie, Pennsylvania, is a joint facility of St. Vincent Hospital and UPMC Hammett that has been providing expert care to the area since 1987. RCC's mission is to provide exceptional care for patients with cancer and blood disorders with a commitment to advanced care modalities, clinical research, and optimal quality of life for patients and families. There are over 100 individuals and professionals on staff at the RCC, including social workers, pharmacists, medical oncologists, nurse practitioners, physician assistants, nurses, social workers, dietitians, researchers, and radiation therapists. Although the RCC is a multidisciplinary facility, throughout our interview, we discovered that there are many needs that could be better met by having on-site occupational therapy services provided to the facility. By opening up discussion and advocating for occupational therapy services, the RCC realizes the benefits of adding an occupational therapist to staff and are open to the idea. These individuals make it possible for those with cancer to receive treatment and support throughout their journey. A study by Mayer and Mendonca called Impact of an Activity-Based Program on Health, Quality of Life, and Occupational Performance of Women Diagnosed with Cancer was an implemented one-week-long program to women who have been diagnosed with cancer to examine changes in this population's health, quality of life, self-perceived occupational performance, and satisfaction with performance. The program focused on improving health, quality of life, and occupational performance with activities including social, cognitive, physical, emotional, spiritual, sensory, and educational components. The program used a pre-test, post-test repeated measure design. They administered 3 outcome measures. This includes 36-item short-form health survey, World Health Organization of Quality of Life brief version, and the Canadian Occupational Performance Measure, before the program on the first day and 6 weeks after the program for a follow-up. The Canadian Occupational Performance Measure was administered additionally on the last day of the program. The results showed that the social relations scale of the World Health Organization of Quality of Life brief version showed significant differences in 6 weeks. Significant differences were also seen with the Canadian Occupational Performance Measure. These results prove that the activity program made a significant difference in improving this population's occupational performance, satisfaction, and social relationships. The results of the one-week program concluded that the activities provided improved emotional and social well-being that led to participants' increased quality of life. Results are also demonstrated that participation in the program can improve performance and satisfaction of occupational performance of meaningful activities. This study is resourceful because it applies client-centered occupational therapy-based activities to women with cancer. The study strives to improve the quality of life and occupational performance for an individual dealing with the effects of cancer. The study proves that incorporating an activity program to this population can lead to significant results in improving occupational performance, overall satisfaction, and social relationships to improve the quality of life for a cancer patient. Hunter, Gibson, Arbesman, and D'Amico conducted a systematic review in 2017, assessing supporting interventions commonly used within occupational therapy in clients suffering from cancer. Researchers specifically reviewed interventions that address psychosocial outcomes, return to work, and sexuality. Researchers found strong evidence that OT psychosocial-based interventions used with cancer patients, involving problem solving and knowledge of illness and progression, reduced both anxiety and depression. The research expressed how articles discussing sexuality and return to work were scarce.
However, the articles were able to find moderate evidence stating that exercise benefits clients' reported interest in sex as well as increases their workability after cancer and cancer treatment. This article also highlights the effectiveness and benefits of a multidisciplinary rehabilitation team when working with this population. Researchers found strong evidence that a multidisciplinary rehabilitation team resulted in improved function and participation regardless of type or stage of cancer or age of survivor. They conclude by stating that cancer patients would benefit from OT in all stages of rehabilitation, despite finding limited evidence of OT intervention with cancer patients in the realm of return to work and sexuality. This is a resourceful article because it highlights effective psychosocial interventions with cancer patients. It also highlights areas of intervention that are largely overlooked during therapy, however, are equally important to the client. Sexuality and return to work with cancer patients are emerging interventions in an emerging population. This article supports the need for occupational therapy with cancer patients as is a helpful tool when highlighting what OTs can and would specifically provide for the Cancer Center.
An article titled Goal Attainment and Goal Adjustment of Older Adults During Person-Directed Cancer Rehabilitation by Lyons, Newman, Kaufman, Bruce, Stearns, Lansigan, and Hagel in 2018 is a study that focused on occupational therapy intervention intended to reduce disability and improve quality of life for older adults during cancer treatments. The article focused on occupational therapy practitioners and their ability to adapt a person's goals in order to keep the individual engaged in meaningful activities and occupations. The pilot study consisted of home-based occupational therapy intervention through a Health Through Activity program. There were 24 participants who set goals that were important to them and wanted to achieve within 6 weeks. Occupational therapists worked with the participants to find out what made those goals difficult to attain, as well as how it could be modified or adapted. On average, participants met 68% of their 6-week goals. Throughout the process, the occupational therapist helped the individual with goal adjustment or goal re-engagement to find the best fit for the client. Participants reported an increase in how often they engaged in the activities targeted by the goals and how confident they felt in their ability to participate in those chosen activities. Occupational therapy is beneficial in this area in order to find the just right challenge for the client and remain as independent as possible in their chosen occupations, as well as retain an increased quality of life throughout the difficult treatment process.
An article titled Women's Experiences of Cognitive Changes or Chemobrain Following Treatment for Breast Cancer, A Role for Occupational Therapy by Player, Mackenzie, Willis, and Yim Low, 2014, stated that research indicates that 30 to 60% of women diagnosed with breast cancer will experience cognitive impairments or chemobrain as a side effect of cancer treatment. Chemobrain has been defined as subtle yet persistent mild mental dysfunctions often experienced following chemotherapy treatment for cancer. These changes are highly individual and may not be fully recognized or understood. The aim of the study was to describe changes in cognitive function experienced by women who have undergone chemotherapy and the strategies used to overcome the associated changes. Participants were breast cancer survivors who had received chemotherapy treatment and self-reported chemobrain symptoms. 6 themes describe the chemobrain experience for these women. They are uncertainty about the origin of the chemobrain experience, persistent but inconsistent impacts on function, simple function turned complex, losing functional independence in family life, strategies to maintain function, and the need for recognition of the subjective experience of cancer treatment. The experiences of cognitive and functional changes following chemotherapy for those reporting chemobrain symptoms are highly individual and include the need for adaptive strategies. As breast cancer survivorship rates continue to rise, there is a need for occupational therapy services to assist women in returning to daily occupations during or following their cancer treatment.
Soderbeck, Peterson, Von Essen, and Stein's 2000 article titled Cancer Patients and Their Physician's Perception of the Former's Need for Occupational Therapy was designed to identify cancer patients' need for occupational therapy as felt by the patients as well as their physicians. This study was performed because the authors felt that there was an underutilization of occupational therapy with cancer patients. The authors highlighted the areas in which occupational therapists could be beneficial to cancer patients by teaching the patient energy conservation, how to use assistive technology, how to independently master daily life functions, how to make adaptations to the home environment, and to be involved in group activities in order to address mental health, coping, and social skills. These include opportunities for patients to express their feelings and help them organize their daily activities. The results of this study found that 56% of cancer patients felt a need for occupational therapy services. 59% of physicians felt that there was a need that occupational therapists could meet for their patients. Overall, the findings of this study were that occupational therapy services are felt to be underutilized by cancer patients and their physicians. This study provides a reference for the importance of occupational therapy intervention with cancer patients. This study emphasizes the idea that occupational therapists and the skills and services they possess and can provide are underutilized as stated by both the cancer patients and their physicians. These findings provide a basis for incorporating occupational therapists into cancer centers such as the RCC in order to promote and provide treatment and intervention with cancer patients to improve their overall quality of life.
The majority of the RCC's population includes adults. They have seen very few pediatric patients over the years. The RCC defines these individuals as survivors. At the RCC, they use the term survivor in many different ways and define survivorship as the process of living with, through, and beyond cancer. This includes individuals who continue to receive treatment to either reduce the risk of the cancer coming back or to manage chronic disease. No matter how it is defined, survivorship is unique for every person. Everyone has to find his or her own path to navigate the changes and challenges that occur as a result of living with cancer. The RCC treats patients with a variety of different types of cancer. This includes lung, colon, breast, and prostate cancer. According to the American Cancer Society, in 2018 in the U.S., there will be 268,670 new cases of breast cancer and 234,030 new cases of lung cancer. Overall, in 2018, there is an estimated 1,735,350 new cases a year. This means approximately 4,750 new cases a day of cancer.
Working within cancer and oncology is an emerging niche within occupational therapy. To best work with this population, OTs would benefit from specialized training in oncology specifically. OTs could attend continuing education courses or workshops focused in oncology to further their exposure and expertise within this specific population. OT practitioners working with this population should know the evidence, keep up with the most current research, and be able to be creative and pull from many areas and models to treat these patients. There is a need for occupational therapists within this population as they have several unmet or overlooked needs, including psychosocial needs, impaired cognition, and fatigue. OTs must address these areas first because they can often mask other needs. When it comes to psychosocial issues, chemobrain, and fatigue, OTs are among the best equipped healthcare providers to address these areas. OTs are also able to treat other areas of oncology patients which often go unmet. For example, OTs can perform scar massage and desensitization for patients who experience pain and sensitivity after an operation. OTs can also become certified lymphedema therapists in order to treat lymphedema, which often goes alongside or comes after cancer. Therefore, occupational therapists in this setting must be competent and current with evidence and research in order to most effectively treat this population.
The RCC staff works as an interdisciplinary team to provide the best care. Currently, the RCC does not have occupational therapists or physical therapists on staff. This lack of therapy services causes other professions to bridge the gap. The interview with the RCC gave more insight to other disciplines' roles. The social workers play a vital role at the RCC. They are in charge of handling transportation needs, employment needs, referrals to the community providers, and resources. They also run grant-funded support groups for children and grandchildren whose loved ones are cancer patients, and support groups for women with breast cancer. The social workers stated they previously conducted a lymphedema program, however, they did not feel as if they approached it correctly since it is so specialized. With the educational background and training that OTs have in anatomy, mental health, and community programs, OTs are best equipped to develop and conduct these types of support groups. The social workers also stated that it is difficult to order durable medical equipment for the patient, and the patients often might not receive it until they are seen for home health therapy, further supporting a need for OTs to evaluate and order appropriate DME for patients. Other staff at the RCC includes radiation oncologists and radiation therapy teams, physician assistants, dietitians, financial counselors, nurse practitioners, and supportive palliative care nurses. All nurses on staff are oncology certified nurses.
Occupational therapy can play a unique role in regards to treating individuals with cancer. Quoted from the AOTA fact sheet, the role of occupational therapy in oncology is to facilitate and enable an individual patient to achieve maximum functional performance, both physically and psychologically, in everyday living skills regardless of his or her life expectancy. End quote. Occupational therapists can assess cognitive as well as physical impairments through assessments such as the Model of Human Occupation, the Canadian Occupational Performance Measure, Pain Assessment Scale, Brief Fatigue Inventory, Rivermead Behavioral Memory Test, Manual Muscle Testing, Berg Balance Scale, Modified Barthel Index, and home assessments. We can gather a client-centered occupational profile and discover what occupations and activities are most important for the client to remain as independent as possible. Occupational therapists can develop a treatment plan as they see fit. This may include a range of motion and strengthening regimen, energy conservation techniques, pain management, scar massage, lymphedema therapy, group therapy sessions, sleep management, modifications or adaptations to activities of daily living, instrumental activities of daily living such as bathing, dressing, cooking, home management tasks, and also work transition programs, as well as side effects that may cause changes in cognition, anxiety, depression, or self-esteem. Education of the diagnosis, what to expect, how to prepare and manage side effects is an area we could assist in. Occupational therapy interventions could be completed within a cancer center, hospital, or even in the comfort of the client's home. These interventions could be implemented into the daily treatment of clients at the RCC, as well as in programs that are already established, such as the Wellness for Life program.
An OT on staff may be able to bill directly to the insurance companies for evaluations and services provided, such as ADL and IADL training, energy conservation techniques, adaptive equipment use, and lymphedema treatment. Grants are already in place to fund the various groups that currently exist at the RCC. These include Wellness for Life, a breast cancer group, a children and grandchildren group, and a Thrivers group for those who have been living with cancer over a prolonged period of time. OTs can further enhance these groups and add programming on transitioning back to work. Achieving health, well-being, and participation in life through engagement in occupation is the overarching statement that describes the domain and process of occupational therapy in its fullest sense. The most significant problem expressed by this population was fatigue. This affects many aspects of their daily life, including self-care like dressing and showering, cooking and home maintenance, leisure activities, and the concern of returning to work are among some of the other concerns. Occupational therapists could be an asset in assessing the RCC patients, making task and environmental adaptations, determining appropriate adaptive equipment, and providing education. During our interview, we discussed an emerging trend that the RCC staff has noticed: the need for transitional services post-cancer treatment. Due to medical advancements, there is an increased survival rate and increased length of life in general. It was found that patients feel lost with the survivorship aspect, meaning knowing what to do now that their whole lives are revolving around cancer and appointments and chemo and radiation. This is well within the occupational therapy scope of practice to help with the transition back to work and establishing a daily routine again. AOTA's Vision 2025 states that occupational therapy maximizes health, well-being, and quality of life for all people, populations, and communities through effective solutions that facilitate participation in everyday living. This vision encompasses the mission and holistic views of the RCC. This population is emerging and underserved when it comes to OT services, which integrates into the vision of serving all populations.
Hi, my name is Pat Gillespie. I'm 58 years old. I have 3 beautiful daughters, 2 grandchildren. Been married for 36 years. Have been with PNC Bank for 41 years, and experience of melanoma about 4 to 5 years ago. Had surgery on my arm and had lymph nodes taken out of underneath my left armpit. As I said, it was melanoma. I've been back to go to dermatologist twice a year. I also visit my oncologist twice a year still. Hopefully at the 5-year mark I'll get released by the oncologist, and I'll probably continue going to the dermatologist twice a year for the rest of my life. But anyway, so that's kind of what the diagnosis was, and then the experience of the whole surgery and the events leading up to it. Had a PET scan, CAT scan, and then again the surgery, again the left arm. Didn't look like much, it was just a dry spot on the arm, but after going to a dermatologist, he discovered the initial find, had that sent out to a pathologist. Went to the oncologist, he did the surgery to remove the cancer from my left arm, and also where the small tumor was up in the lymph nodes. I still have limited range in my left arm, still have a little bit of pain with the left arm as well too, but never went to occupational or physical therapy after the surgery. The surgeon felt that it wasn't really necessary for me to do that. Kind of sorry I didn't go to OT, because I think that might have helped the healing process, as well as the range movement in my arm. So, but overall, cancer survivor, and that's the biggest part of my story. Thank you.
Hi, my name is Connor. I am 23 years old, and my role currently is a student at Gannon University in occupational therapy, and currently working for the Barber National Institute. My diagnosis is testicular cancer. I was diagnosed in the first week of December 2017. Everything moved very fast. Within the first week, I was under for an orchiectomy to remove the tumor. And we were just after that, waited around to see what the biopsy results would be. Came back positive for non-seminoma cancer. I was then referred to a urologist in Cleveland, who would then perform my second surgery, which was a retroperitoneal lymph node dissection. That was due to the fact that imaging had shown the cancer had already spread to my lymph nodes, but they weren't 100% positive just based on the CT scan results. I elected for the surgery, which was done on January 2nd, 2018. I spent 5 days in Cleveland Clinic recovering. I've had numerous side effects. Mostly from the surgery was pain. I have about a foot-long incision from bottom of my breastbone down across my waist. It was just a lot of pain. I don't think I was mentally prepared for the experience. I woke up from surgery feeling like I was hit by a bus. And from there, it just each day slowly got better, but it really did. It took about a month and a half for me to finally wake up and not have that severe pain. 2 weeks after my surgery, I got biopsy results for my lymph nodes. They tested positive for cancer. I think the numbers were I had 40 lymph nodes removed, and over half of them tested positive for cancer. Which then referred me to medical oncology, which was a real bummer because I went into the surgery the second time thinking this was it. This was the last thing that I'd have to do. But it wasn't. Met with oncology beginning of February, and we just kind of came up with a plan. You know, most TC patients experience or go through 3 to 4 rounds of chemo. We were going to have a PET scan done the week prior to the start of treatment, and that would kind of dictate how many rounds I would need. Luckily, I had good results, and the doc said that I would only need 2 rounds. The 2 rounds took me 6 weeks to complete, 3 weeks for each round. The first week of the round would consist of me going and receiving chemotherapy for about 7 hours a day, 5 days a week. The following 2 weeks of the round, I only would have to go 1 day, and that was for a short hour treatment. The chemo definitely took more out of me than I had initially anticipated. The biggest side effect that I experienced was the fatigue. It is amazing because I would get up, I'd get in the shower, and within 2 minutes of just standing there, I would need a seat. I would need to sit down. I'd be exhausted. And it took more out of me than I was expecting. But other side effects included the lack of taste, bruising easily, just losing my hair was a big thing. But I mean, a lot of those have already kind of subsided. As of the beginning of April, I am technically in remission. I have not had a PET scan done yet since my treatment has ceased, but I believe until imaging tells me otherwise, I'm in remission. Any kind of therapy that I received throughout the process mostly would have been at my 5-day stay in Cleveland Clinic. I never formally received any physical therapy or occupational therapy, but the big thing is that I had a checklist of items and things that I would have to do before I was discharged from the hospital, and one of those was getting up and moving around. So I'd have the nurse or the nurse's assistant come into the room, and if I had been in bed for a while, say, hey, we need to get up, we need to walk down the hallway and come back. So I got up, IV in, and everything attached to me. I carried my IV pole, and I would walk down the hallway, and I'd walk back. The first couple of days I had no interest in doing it, but come the 3rd day I realized it was something that I needed to do to get out of the hospital, so I became a little bit more motivated. And I did those things. I do think occupational therapy can be utilized in most oncology patients, including testicular cancer patients. I never received any formal occupational therapy, but I do think in a group setting, occupational therapy can be very beneficial. Being able to have a support group, especially made up of those with similar diagnoses, if not my own diagnosis, it definitely would have been beneficial. Something that kind of encouraged me to get up and move around. There's all sorts of... I think of Dr. Hatjar's group class, where we would orchestrate our own groups. There were a lot of activities where we would just get up and move, and it wasn't physically grueling, but just 5 minutes would be enough to, get up, move around, and then be able to, dwell on our own experiences with our diagnosis. I definitely do think that occupational therapy would be beneficial.
Our findings from evidence-based practice, as well as the services of the Regional Cancer Center, it is clear that the significance of occupational therapy intervention with individuals with cancer is invaluable. Occupational therapy can have a special place in this setting. Interventions can encompass physical, cognitive, and emotional well-being of individuals. Advocacy will only lead to an increased presence with this population.